Hi, everyone. Welcome to the second day of HARC. This is oral abstract session number 4. I'm Shauna Yin. I'm an associate professor of pediatrics and population health at the NYU School of Medicine. And my research focuses on health literacy and how it intersects with child's health outcomes. Excited about our abstract presentations today. Each participant will have 10 minutes to present, followed by 5 minutes for questions. And if there's time at the end, we can have the speakers back for some additional questions. While the speakers are presenting, feel free to submit your questions. There's a button on the bottom called Q&A, so please do submit your questions there rather than the chat. I'll try to monitor both those things though. And so we have 4 presentations today. Our first presentation is from Chelsea Dade from the Kaiser Family Foundation. Chelsea, would you like to share your screen?
Sure. So good morning, everyone. I am Chelsea Dade, and I'm the Community Engagement Manager on the Social Impact Media team at Kaiser Family Foundation. And I'm here to present a little bit of a different type of presentation than some of the ones that we've seen previously. This one will really emphasize community engagement and how it's connected to health literacy and how it's backed by the research at Kaiser Family Foundation. So first and foremost, KFF, we focus on pressing health issues in the US, and we are not affiliated with Kaiser Permanente. So I mentioned earlier that this presentation is about the conversation, la conversación, and so you might be wondering, what is the conversation? So back in January of this year, KFF decided to take a look at who was most interested in receiving the COVID vaccine and who was not interested in receiving the COVID vaccine. And so, as we expected, there were severe racial and ethnic disparities, specifically for Black adults and Hispanic Latino adults, with most of those folks in kind of the wait and see category. And of course, you know, that's fair. The vaccines were new, and there's a lot of information that we didn't necessarily know yet. And so people, of course, you know, had questions. So what did we do? We asked folks what those questions were. And then what we received in response was that the things about long-term effects of the COVID vaccines, or how someone would get a vaccine, or even if the vaccine is safe, those were the most pressing questions. And specifically for our Black and Latino adults. And so those were the concerns that we were hearing when we were out asking people about what they thought about the vaccines. So with this information in mind, we also decided to ask folks about what would influence them or encourage them to seek out more information about the COVID vaccine. And so what we heard was that for Black and Hispanic folks, the majority of adults in those categories, they were more likely to turn to a doctor, a nurse, or another healthcare provider for more COVID vaccine information, as opposed to other sources. So as opposed to family or friends or a public health department. This in turn is what came about, which is the conversation, la conversación. And at this time, this whole series is kind of a living library with over 200 videos that are each identifying one or more facets of the COVID vaccine, whether that is the safety process, the development process, how vaccines affect pregnancy or fertility. And so a lot of people had questions about those topics, and that's what we wanted to focus on. In addition, the research that we have at KFF, in combination with other research that emphasizes the importance of messengers that are from the community, so that look like the community, that are from the community, that understand the community, that is why we focused on these messengers for our campaigns. And so in the first series, we had the conversation between us about us, featuring Black healthcare workers. We have your doctors, your nurses, your researchers, and then oops, going back. And then in May, we launched the conversation, La Conversación, which focuses on Latinx doctors and promotoras and real health leaders in the community. And then more recently in August, we launched the conversation about the COVID vaccines and kids. And then we brought once more, again, our doctors, this time our pediatricians. So the conversation, again, as I mentioned, has over 200 videos that are addressing a lot of your most common questions about COVID vaccines from the perspective of people in our communities. And so that community element is very core to this, this campaign and this series. In addition to creating the videos, you know, the key way to get community buy-in or input is working with community partners. And so we've been fortunate to connect with a lot of great individuals and groups to really share out this work that we have been, you know, committed to for the past year. And some of those partners are listed here, but I'll go into a little bit more depth about who those folks are. So I pulled a few screenshots of the events themselves, just because they tell the story of, you know, what we were working on and why it's so community oriented. So this is one event that we did with a faith group in New Jersey. I mean, you can kind of see that the video is shown at the beginning there. So the videos themselves work very well as webinar openers or town hall openers, because that's what, you know, the event is about. It's about creating a conversation. And then here's another event that we did with the National Pan-Hellenic Council, just because, again, the National Pan-Hellenic Council is very key, specifically for the Black community. And then we had another event with the National NAACP, as well as the Black Women's Health Imperative and Made to Save. And again, you know, we played the video at the beginning to start off the conversation about COVID. And as you can see, you know, from all these examples that I'm pointing out, the importance of having messengers that look like the community is very key and very crucial for having these conversations. And then here's another event that we did with Ebenezer Baptist Church back in March. On kind of the other side of this conversation, you know, social media plays a very key role in community engagement, especially for our millennials and our Gen Z. And so sometimes we will use Twitter, Twitter chats, Twitter storms to also have conversations about COVID and the vaccines. So at this time, we have reached over 100 million views on YouTube, which is very, very exciting. You know, many minutes watched. And then of course we have our lovely healthcare workers featured. And so this is really a group effort, the conversation, La Conversación. It can't be done without our partners. And it's just been a great moment. So for more information on the campaign, you can visit betweenusabout.us.org or on YouTube at Greater Than COVID. And these are our social handles. Let's go back. And then there's my contact information. And I'll just finish with this. Our campaign, you know, we are evaluating the impacts of it and where it's reaching, but we do plan on doing more of that evaluative process in the coming months. Thank you.
Thanks so much, Chelsea. Can you, so the floor is open for questions from the group. Are there any questions? And while we're waiting for those, if you can enter those in the Q&A, using the Q&A button, that would be really helpful. And while we're waiting to see if there are questions, I have some questions to follow up. That was a fantastic presentation and really exciting, the work that you're doing. I wonder if you were commenting at the end about evaluation. Can you talk a little bit more about what your plans are and how you will evaluate? And it looks like this is a really like a national effort, and so how that seems like it may be complicated to look at impacts, but it would be really exciting to see what the impacts are in terms of uptake of vaccines in various communities. Can you talk a little bit about what you are envisioning might be part of that evaluation plan?
So as I mentioned, we've been evaluating the types of groups that have been engaging in the conversation. So our faith communities, our civic groups, but mainly that has been, very qualitative. It's been based on, general one-to-one interviews. So you're absolutely right. Evaluating this national campaign will definitely be an effort. There will be more people. There are more people on our team who are further engaged in the evaluative process. And so I'm happy to connect anyone who's interested in that with them from our team.
Great. There's a question from the audience about, and it's from Samantha Belfridge, about what you think is contributing to the really high number of views that you're getting. Which of the things that you've developed have gotten the most views, and why?
Yeah, that's a great question. Well, we do have a combination of efforts. So we do have paid placements in addition. So we are reaching folks through paid placements, and then also, the individual one-on-one outreach, our group outreach. So we're reaching people in different ways. And I would say some of those large number of views probably do come from the paid placements, the targeted placements by zip code. And so we are making sure that we're reaching, the right folks, the people who are in areas that do have very low vaccination rates through, again, paid placements and other targeted outreach.
Great. And can you tell us a little bit more about your process for deciding who to collaborate with? And, once you decide who to collaborate with, how does that process evolve and before you develop kind of the product that gets shown to everybody?
Yeah, another great question. So many great questions. Well, as I mentioned earlier, the partnership element of this is so key. And so, for example, I can talk a little bit about our partnership with the organization in Georgia, Fair Count. And so they primarily are focused on voter education. But when COVID was, in all of our lives, they had to kind of do both things at the same time. And so we got connected with them to help support the CBOs, the community-based organizations that they were already working with through voter education to help them do, COVID vaccine-related outreach. And so we're looking at who has really deep ties to the community. And if that organization has those deep ties, then those are the folks that we want to be working with.
Great. And once you identify those groups, then how does that work? How long does it take to develop something or plan out what the messaging will look like for that particular group? Like, is there what kind of process do you undergo for that?
Yeah. I would say it's collaborative. We'll have regular touch bases with the community partner and decide, what is the vision of whether it's a digital material or a print material. So we'll work with them on what that looks like. But yeah, it's a collaborative process.
Great. And then there was a question from the audience about social media and what do you think is working well with the social media campaign? I know you mentioned some things about Twitter.
Yeah, well, I think that's really the strength of the campaign is that we are reaching folks with our print materials. There was a time when it was mainly in the summer through June through August. We're working with our printer to get print materials that are kind of demonstrating or showcasing the conversation content. And then we were shipping out a combination of buttons, door hangers, and palm cards out to different community-based organizations. So we were doing that for groups that are really boots on the ground. They're, going door to door, trying to get this information out. But then also we were focusing on our graphics, our digital pieces, our social media banners, making sure we're following all the community-based groups that we are connecting with. So the fact that we're working on both fronts, I think, is really the key to the strength of it. And then we also just have a really great social media digital team. I have to, give claps for that, the folks who are working on that on our team.
Great. Can you speak to any of the differences in the different subgroups, and what are you feeling is reaching most to certain subpopulations, younger versus older, or in certain racial ethnic groups?
Yeah, messaging, all about the messaging. I think this is similar to the last answer that I gave. We are pretty open to, really using Instagram or considering other ways to reach folks, like whether that's like Twitter circles or, other ways to reach the younger generations. That I think is key. Being open to trying out new ways of outreach. I think that's really a key way to kind of get this messaging out. Not being afraid of trying out new things, because really that's what this campaign is about. I don't think I've ever seen any campaign that's looked like this, quite honestly, and so it's great to be a part of because it's new and it's innovative.
Great, thank you. It's really, really exciting, the work that you're doing, and I love the reach that you've had so far. Excited to hear more about the next steps. Thank you so much, Lucy. So we'll move on to our second presentation, which is by Samantha Belfridge. This is a collaborative work from University of Winchester, University of Southampton, and Southampton Children's Hospital. Feel free to show your screen, Samantha, and definitely enter your questions and answers while she's chatting. So we'll have a great conversation afterwards. Thanks. Go ahead, Samantha. And you're muted.
Sorry, yeah, found the button, unmuted.
No problem.
Brilliant, thank you. I think you can all see my screen now. So yeah, welcome everybody, thank you. I'm Sam Belfridge, and I'm a first year PhD candidate from the University of Winchester in the UK. I'm thrilled to have the opportunity to share my initial research with you. I'll be presenting an overview of my systematic review, and it's a review of community-based interventions aimed at improving health literacy of parents and carers. My thank goes out to my co-authors, Dr. Margaret Husted, Dr. Simon Fraser, Dr. Sanjay Patel, and Professor James Faulkner. So just moving on to an overview. This is the overview of the journey we'll be taking together over the next 10 minutes. I'll be starting with a brief background and moving on to the research aim, methods, results, discussion, strengths and limitations.
All right, great, thank you.
Our conclusion, recommendations for the research, and there will be time for any questions at the end. So I'm just going to move on to the background. And evidence shows that inadequate health literacy amongst parents or carers is associated with ineffective and decreases in preventative behaviours such as vaccination uptake. It's also associated with worse child health outcomes such as poorer oral health and higher rates of obesity. There is also evidence to suggest an increase in emergency use, which not only increases stress within the family, it adds pressure to already stretched services. And to our knowledge, there have been many community-based, and by community-based, I mean not inpatient and not clinical, interventions developed to increase the health literacy of parents and carers. Yet to our knowledge, there was no systematic review of their effectiveness, which leads me on to tell you what our research aim was. So our research aim was to conduct a systematic review to examine the effectiveness of community-based health literacy interventions in improving the health literacy of parents and carers. So how did we do that systematically? Let's take a look at the methods. We searched the 6 databases listed on the screen, and there was a search of the grey literature, including Open Grey. We set the eligibility and exclusion criteria following the PICO framework. All quantitative and mixed method study designs were considered. However, only the quantitative health literacy data was synthesized. And this synthesis was guided by the SWIM guidelines, which stands for synthesis without meta-analysis. Studies were grouped by study design, which meant we had randomized controlled trials, non-randomized with comparison groups, and non-randomized studies without comparison groups. 2 reviewers screened all titles and abstracts, and then full text. Data was extracted and 2 reviewers carried out the risk of bias assessments. So let me move you on to the start of our results section. So what did we find out? Our electronic database searching identified 10,091 papers. One additional unpublished study was identified from the Grey Literature Search. However, we were unable to reach the authors to actually gain access to that study. After removing duplicates, there were 5,581 unique publications, of which 5,439 did not meet our inclusion criteria. Of the 142 papers retrieved for full text review, 131 did not meet the inclusion criteria, with the primary reason for exclusion being that there was no reported health literacy outcome, that it was a conference abstract, or that it was a study protocol and the results were not yet available. I'm going to show you a table of our included studies. Hopefully you can make out some of the detail on there. So from the table, you'll be able to see that there were 4 included randomized controlled trials. 4 are, oh, sorry, I should have said that. From removing the duplicates and the full text screening, it left us with 11 papers. And of those 11, 4 were included. 4 of the included studies were randomized controlled trials, 4 are non-randomized studies with comparison group, and 3 are non-randomized without a comparison group. Date of the publications ranged from 2017 to 2021. Studies were conducted in a wide range of countries, including New Zealand, Brazil, Turkey, Japan, Iran, Portugal, Australia, England, and the US. The studies also focused on a range of health domains, including mental health, oral health, physical activity, nutrition, maternal health, and more. It's important to note that the interventions were also delivered in a range of ways, including text messaging, web-based programs, and also face-to-face. So I'll move on to our risk of bias of those included studies. So all the randomized controlled trials have a high risk of bias overall, and this was predominantly arising from concerns around the outcome measures used and the selection of reported results. Of the included non-randomized studies with comparison groups, the overall risk of bias is high for 2 studies, moderate for 1, and low for another. Of the included non-randomized studies without a comparison group, the overall risk of bias is high for 1 study, moderate for 1 study, and low for another. And we can see the overall results just there on the right-hand side. Okay, so we created a forest plot, to visualize the effect size as reported as a standardized mean difference. As you can see, the forest plot doesn't have its usual diamond, as the study's effect size have not been combined due to the heterogeneity of the studies. The effect size distribution is positively skewed in both study designs, so that of the randomized controlled trials and that, oops, sorry, let me just get back to the right slide. Here we go, there's the forest plot. The effect size distribution is positively skewed in both study designs, so the randomized controlled trials and the non-randomized studies with a comparison group. With the effect size mean being larger than the median. Using Cohen's d effect size interpretation, the randomized controlled trials showed a median positive effect, d equals 0.53, and the non-randomized studies with comparison group show a large positive effect, d equals 1.03. However, when the outlier is removed, which is the final study on the forest plot, Hurley 2021, with that outlier removed, the effect size reduces to small. Okay, moving on to our discussion then. So this systematic review identified a total of 11 studies delivered in a wide range of settings, delivered by various methods and on a range of health topics. Due to this, the range of tools used to measure health literacy and the risk of bias of the included studies, it's not possible to make an overarching statement about the effectiveness of these interventions on improving the health literacy of parents or carers, though there are suggestions that the improvements were made in many of these studies to the health literacy of parents and carers. Despite this, the review has highlighted several points worth discussing, which I want to bring to your attention now. So the first being the limited number, just 5 of the 11 included studies, that described the theoretical underpinning of the intervention that they developed and delivered as part of their study. And previous research shows that interventions grounded in theory result in improved outcomes. The review also highlighted the need for researchers to consider the appropriateness of the health literacy measurement tools used in measuring change in health literacy post-intervention. So I want to give an example of this. So from the studies that we included in this review, tools that we used to measure health literacy included the Rapid Estimate of Adult Literacy in Medicine, REALM for short, the Short Test of Functional Health Literacy in Adults, and the newest Vital Sign UK. And all of these are screening tools designed to be used to assess levels of health literacy rather than as a tool to measure change. For instance, REALM's restricted focus on health-related word pronunciation really does prevent it from being an effective tool for measuring change in health literacy. Furthermore, and another consideration is the ceiling effect. It's an additional measurement limitation of some of these tools that have been used. Specifically, this was seen in studies where mental health literacy was already high at baseline, meaning that there was limited opportunity to increase the score within the intervention. Therefore, the effectiveness of the intervention needs to be interpreted with caution. Now I'll move on to our strengths and limitations of our systematic review. There was a broad search strategy, which we feel is a real strength to the study. There were 2 reviewers used, so evidence shows us that we're more likely to capture a wider range of studies and reduce the chance of missing any studies. And the use of the SWIM guidelines allowed us to synthesize without meta-analysis and just offer a little bit more than purely a narrative synthesis of the individual studies. Some of the limitations are that there was a limit on the language. We only included studies that were published in English, so there's potentially some studies there missed. And there's also the potential for publication bias, especially being unable to contact the author to find the study we would have liked that was identified from the grey literature. So let me move on to our conclusions. So community-based virtual and face-to-face health literacy interventions have emerged as potential methods for enhancing parental health literacy. However, a definitive conclusion on their effectiveness cannot be drawn from this review due to the heterogeneity between the studies, even those when they were grouped as the same study designs. The review has highlighted a need for more theoretical and evidence-based health literacy research, which captures the long-term impact of the intervention. And that was another thing that we found from the review, that many of the interventions only measures the health literacy post-intervention, and that might have been as short as the same day that the intervention was delivered. It might have been like 2 weeks after, and I think the longest was only 6 weeks after intervention. So that long-term impact wasn't measured in any of those included studies. Okay, so our recommendations, thinking in terms of research. So from the review, we feel that there's a need for methodologically stronger primary research. So really thinking about what is the theory of the intervention, why should it be working? That there's a call for longitudinal design so that we check in to see what the impact of the intervention is over a longer term, both for the parent and carers and then potentially for the children as well. And also consider the suitability of using screening tools to measure change in health literacy post-intervention. And for practice, there are some implications, even though there's no concrete, we can't make a definitive answer on their effectiveness. The review still highlights that the low cost of virtual interventions could be successful at improving parental health literacy. So a couple of the studies included used text messaging, which showed promising results at increasing health literacy, and also the benefits of brief interventions. So again, there were positive findings from just one-off interventions. So we don't want to dismiss those findings, but we need to interpret them with caution. Okay, and that leaves me to the end and to any questions.
Fantastic. Thank you so much, Samantha. That was an excellent presentation and really interesting work that you're doing. We do have some questions from the audience. First question, this is from Andrea Morrison. Does your definition limit the number of interventions, and you may have missed other effective studies that were out there? For instance, was there an opportunity to include a study that wasn't necessarily labeled as a health literacy intervention?
Yeah, that's a really great question. So the study didn't have to be labeled as a health literacy intervention, but it had to have a quantitative measure of health literacy. And that's a really important finding, actually, that of our 11 included studies, I think it was less than half actually were looking to explicitly improve the health literacy. Others were more of a byproduct, that they were measuring it at baseline and then they were measuring it post-intervention, but it wasn't necessarily the focus of the intervention.
Great. And then can you talk about, in looking at your studies, it looked like, you know, in terms, looking at impacts of health, of the intervention on health literacy, did they have impacts on other outcomes that were interesting or exciting?
Yeah. So one of them, for example, was about immunization, and that particular study was looking at communication between two parents, and it was about having a brief intervention. They were 2 sessions with a researcher talking about the benefits of immunization in children. I think it was in their first year of life. This was a study based in Japan. So that had really interesting findings about that communication and decision making within families, which made me think about distributed health literacy and how important that is. Where are you seeking to ask questions before your decision making, and who else is supporting your decision making and health literacy? It was a really interesting study.
Great. And then just one last question. I wondered about, you mentioned there's lots of risk of bias that you found in the studies. Can you comment on some of those sources and how studies might be improved to address those?
Yeah, absolutely. So some of it is around that you can't be blinded to the intervention. So the participants are knowing that they're taking part in a health literacy intervention. Some of it is around the self-reported bias, that parents are potentially scoring themselves higher or thinking they're answering in a socially acceptable kind of way. And also some of it was down to the results that were reported in the published paper. So some people had used health literacy measurement tools, but only reported the findings of a subset of it. So around mental health literacy, one of the papers had really focused on, I think it was seeking information. There was a domain on that. So their findings, they weren't reporting everything that they had collected and measured. And that was one of the reasons that the risk of bias was increased.
Great. Well, thank you so much, Samantha, for that great presentation and for this great work. I'll move us along to our next presentation. So our third presenter is Jennifer Gann from the University of Arkansas for Medical Sciences. If you can share your screen.
I think somebody else has to, there we go, stop sharing. So share. Okay, just give me one moment to get back to.
And keep those questions coming in the audience if you want to use the Q&A button, and also monitoring the chat as well. Please submit your questions. Go ahead, Jen.
Okay, well, thank you, everybody. So my name is Jennifer Gann. I work in the Center for Health Literacy in the Department of Medical Humanities and Bioethics. And I'm representing my co-authors, Allison Caballero, Kat Neal, and Wendy Ward, and presenting on the effectiveness of interprofessional education curriculum to teach health literacy best practices at the University of Arkansas for Medical Sciences. So there's many clear connections between health literacy and the quadruple aim. So there's research that demonstrates the relationship between health literacy and healthcare costs. We also know that patients at risk for limited health literacy skills may have different patient experiences than others. And there's quite a lot of evidence that links health literacy to health outcomes, and that's both at an individual and population level. And we also know that it can lead to the affect the fourth aim, which is provider experience. So we know that clear communication affects all aspects of the quadruple aim. And so we know that there's increasing emphasis on organizational demands for health literacy, as evidenced by the 2 recent definitions from the Health Literacy Healthy People 2030. But we do know there's room to grow. We don't teach these skills consistently across professions or institutions, and we see that less than half of family medicine residency programs teach health literacy skills. And that practice plays out in studies like this one that show that there's several recommended practices, such as teach back, that aren't consistently used by providers. And this is true across all professions. And just so we're on the same page, interprofessional education occurs when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. And these are the 4 competencies of the interprofessional educational collaborative, and their values and ethics, roles and responsibilities, and then effective interpersonal communication. And this includes patients, families, communities, and other healthcare professionals, and then teams and teamwork. So in 2014, the UMS Center for Health Literacy was established. And then shortly after, the interprofessional education office was launched, and their curriculum, which was a campus-wide graduation requirement, included health literacy from the beginning. And since this has been published, we have integrated the health literacy competencies into the IPE curriculum. And just to kind of give you an idea of the different phases, the first event is exposure, and that is for learners, new learners. And just like it sounds, it's an exposure to core topics, which are important across healthcare professions, including health literacy and health communication. Then they do a bridge activity, and that where they attend a movie night or volunteer at a student run health center. And then they submit a reflection paper on their experience. And that leads into the immersion phase, which is for intermediate learners to work in interprofessional teams on a range of different topics with partners from other colleges and programs. And then after another bridge activity, they can enter into the competency phase. And this is where they really take a deeper dive into a particular topic. And this is for the advanced learners. And they apply their skills that they've learned to either a particular problem or a case. And then health literacy is really the first topic that has events to meet all phases of the IPE curriculum requirement. And so I want to just take a minute to kind of talk through how we integrated some of the health literacy work across these 3 phases of the IPE curriculum. So first, in the exposure phase, we really wanted students to, which typically new learners, and which typically is when this course is taken, to relate to health communication to their own personal and professional experiences and goals, and not think of it as something separate or extra. And we really do this by linking it to the quadruple aim, linking it with ethical imperatives, and then linking it to their moral desire to help others, which is really why a lot of people got into their profession in the first place. So we wanted something for learners to take away from each of these events. So for this exposure workshop, we focused on identifying jargon. And so they were introduced to the different levels of jargon. It didn't have to be necessarily scientific. It could be industry specific, or if it wasn't industry specific, it just wasn't in living room language. And then we do kind of leave them to challenge to identify jargon in their own work, and then let them to also know to speak up about jargon across professions. So we know that each of them will have a different exposure to terminology throughout their education. So we really encourage them to ask questions and speak up if they don't understand a word or think that it's jargon. And so for this format, and like many, we had to shift to the pandemic to virtual events. So there's 2 parts. First, they watched pre-recorded videos on the core concepts, and that could be quadruple aim, patient and family-centered care, as well as health literacy and cultural competence. And then they attend a live session where they go into breakout rooms, and this is in an interprofessional mix of healthcare professions, and they discuss a family case study. So they really discuss how the principles of health literacy apply to the family case and how communication could be improved. Next, we go into the immersion phase. So I've been the lead facilitator for all of the quadruple aim proposal workshops for the past 1.5 years. And here they have an interprofessional group of learners, and they work together in small teams to develop a quality improvement project. So last year we built one specifically around health literacy. So the teams build a proposal to either develop a health literacy month campaign, and that's to build awareness among healthcare professionals. They can also do a project to reduce barriers to the use of digital health resources, and that's like patient portals or telehealth. Or they can choose to improve medication adherence by improving communication. So for this event, the format is large group that gets a brief introduction to quality improvement projects. Then they have a review of health literacy and the quadruple aim. Once they go into their smaller breakout rooms, and this is really about 10 students, and each room has a subject matter expert as well as a facilitator that move between the rooms to guide the discussion. So in the proposal, they develop a mini proposal, and we really wanted them to think not only about, the objectives, about what do I want to do, but why does it matter and what data do I have to support it? We also asked for them to think about how will I evaluate and measure that data or that information and the success of our project, and how they can work very intentionally to make everything they do interprofessional. And this is in order to get buy-in and also have a bigger impact. And then for this event, just as a tip, we recommend using Google Docs for co-editing, which for many of these students is their first time doing co-editing live. And so that's been really helpful for a lot of people. And then the last phase is the competence phase, and this is really for advanced learners. And this is where they apply the competencies that they've learned about interprofessional education and collaborative practices. So they take a deeper dive again into that quadruple aim and its relationship with clear communication. They spend a lot of time in their small interprofessional groups, and they discuss why it matters. So the different groups have different communication practices settings. So one group may discuss, for example, research. And in there, they would talk about why clear communication matters across the entire life cycle of the study. And they might discuss what happens when it doesn't go well, or what some of those barriers are. And then I'll talk about that last bullet point next. But each group shares their takeaway with the others when they come back into that larger room, and they get a little lesson on plain language tips. So after this very brief mini lecture on plain language writing techniques, they will go back into their breakout rooms and review a sample document. And we ask them to make this document easier to understand by providing specific recommendations and edits based on what they've learned. So one of them is a survey, and this is because in the previous session, they really discussed how important surveys are, and not only in research, but in patient care and in public health. So the learners will work together to look for opportunities to make the survey better. For example, basic things like word choice, format design, readability, and actionability. And then another tip for this session was that the facilitators did not need to be health literacy content experts. We provided them with a very detailed facilitator's guide. And then as extra support, we had health literacy specialists from our center floating in between the rooms. So we do have some preliminary results. The learners in the exposure workshop rated the communication section as excellent. So that's the top rating on a 4-point Likert scale. And then the students' scores on universal precautions knowledge question did improve by over 60% after this initial workshop. And I think one of my favorite findings is from the immersion phase, that quadruple aim proposal, where over half of the learners said that if this was a real project, they would want to be a part of it. And to me, this says that they value the role that they can play across these health professions in communicating clearly with their patients and the public. And then lastly, the plain language writing workshop in the competency phase, there was 44% increase in agreement with the statement that it's important to promote effective communication among interprofessional teams, which we really emphasize includes patients and their families. So next steps, I just recently received the raw data from all of our most recent events. And so I'm really excited to dig in and see what else emerges. And I will be looking forward to presenting this as hopefully a research of progress for the International Health Literacy Association Research Special Interest Group. So that'll be exciting. And even though these materials can be used for future workshops, we will continue to update them, the exercises and case studies to make them to keep up with what's happening around us. And then the next piece of the health literacy curriculum that we want to develop is really this interprofessional simulation learning sessions. So we're looking to add some of our the health literacy competency into those learning objectives and the facilitator and standardized patient packets. And then lastly, we are really working with other campuses across the state to include in these events. And with being virtual, we're allowed to have more access to others and participants. So I'm really grateful for my teammates at the Center for Health Literacy and the Office for Interprofessional Education at UAMS. They really do make these learning events fun and successful. So I appreciate your attention and the opportunity to share this project with you today. I do have some references, and if you have any questions or want to reach out to me, here's my contact info.
Thank you so much, Jennifer. This is really interesting work that you're doing there, really important. We have a question from the audience. What were the hardest parts of getting this work going at your site?
Well, I would say I think really the hardest part is, having buy-in from the institution. I think, having the interprofessional education requirement has been really important. And I've noticed that even since the pandemic, there has been so much more interest from the learners to really want to work and learn from each other. I think the other part is just coordinating. It is the Interprofessional Education Office. They're handling so many different events, and it takes a lot of coordination, both on the front end and the back end. And then even to the point of having to ensure that you have a real interprofessional mix of students in each of those sessions so that they can learn from each other. Thank you for that.
One last question. I wonder if you can talk about the faculty and professional development for faculty, and if there have been specific challenges related to that.
That's a great question. So we do have a really nice, we have two pillars. One of them is for a student pillar, so that's designing events, and that's kind of a core group of faculty that discuss that. Then we have a faculty pillar. So in that faculty pillar, they do have a method of certifying people as facilitators. And I'll tell you, with the online events, it took at least double the amount of facilitators to organize this. So we really had to provide that opportunity. We did some crash courses so that they kind of get an idea of the event, and those were recorded. And then the faculty not only get exposure to these different topics and working with others, but they also get credit for their promotion and tenure packets. So that has also been a benefit to get some buy-in from them. And I am hoping, I do think that just having the faculty come up with different types of events, that kind of gets them in this interprofessional thinking mode as well.
Great. Thank you so much, Jennifer. I'm going to move us along because we're running out of time and we have one more presentation. So thank you so much. Great presentation. Our next speaker is Laura Koo from the University of Maryland School of Public Health. We can switch the screen so that we can see Laura's. I can see your screen, Laura, but I don't see your face. That would be great.
Can you see me now?
I don't. I don't know if others can. I still see Jen.
You can? Okay.
Yeah,
All right, and you can see my screen?
I can see the
Jen-
screen. Maybe you can just start and then we'll try to fix the whoever's getting pinned.
If you might, Jen, if you're still pinned, if you might turn off your video, that might help. And
All right, well, I'll go ahead and get started. The title of my presentation is Empowerment May Mediate the Relationship Between Health Literacy and Advocacy. Today's presentation describes a part of the results of my PhD dissertation that I successfully defended about a month ago at the University of Maryland. And I would like to forward my slides. There we go. Express the deepest appreciation for funding that made this project possible through the Rima E. Rudd Fellowship in Health Literacy and the Biology and Behavior Across the Lifespan Facilitation Award. I am having trouble with forwarding my slides, although I didn't in practice. Can be done here. My apologies. There we go. Okay, and I would also like to express gratitude for my mentors through the dissertation process. The objective of this research was to examine the relationships among parental health literacy, empowerment, and advocacy in the context of food allergies management in elementary schools. I did an online survey of parents of children with food allergies. Food allergies can be life-threatening, associated with severe allergic reactions called anaphylaxis. The elementary school setting may increase the risk of fatality associated with food-induced anaphylaxis because of delays in recognition or treatment of it. And understanding how to manage food allergies may require high levels of health literacy. Health literacy is described as having 3 dimensions by Nutbeam: functional, communicative, and critical health literacy. And health literacy challenges associated with food allergies in these dimensions include reading food labels and communicating with others about how to avoid allergens to prevent a food allergy emergency. Parents' low levels of health literacy, as one of the previous speakers described, are associated with health behaviors that may not be helpful for their children compared to parents who have higher levels of health literacy. Yet parents are often the ones who drive the implementation of food allergy management safety practices in local schools. And in the literature, the relationships are unclear among health literacy, empowerment, and chronic disease management. There are several health literacy models or frameworks that include a psychosocial mediator between health literacy and health outcomes. One of those is empowerment, and there is mixed evidence about it as a mediator. Often, and we heard this with the systematic review, health literacy is measured predominantly as a proxy through measures of functional health literacy. Yet this might not capture the whole conceptualization of health literacy. In this study, the hypothesis was that empowerment mediates the relationship between parental health literacy and advocacy. Then beyond the study box, the parental advocacy leads to health behaviors in the schools, such as methods for preventing allergen exposure, and then health outcomes such as allergic reactions. The inclusion criteria for the study was that the participants must have been parents or guardians of children with life-threatening food allergies, and that should have been diagnosed by a healthcare provider. The child must have attended elementary school within the 12 months prior to the study in the United States in person, and a small incentive was offered for the pilot study and the main study. To develop the measures and refine the methods for this study, I used an iterative process, starting with adapting measures for food allergies, performing 3 rounds of cognitive interviews, then revising, doing a pilot study that developed some initial retest reliability and validity for the scales, and further refinement for the items, measures, and the online survey flow. The main measures consisted of scales that had 3 subscales and 5 response options in Likert-like ways. The parental health literacy scale was based on Ishikawa's functional, communicative, and critical health literacy scale and adapted for parents of children with food allergies. The parental empowerment and advocacy scales were adapted and created from the literature. During the winter of 2021, 27 food allergy organizations distributed ads for the online survey, and the final survey number was 313 participants. It took them about 20 minutes to complete the survey. The participants were predominantly Caucasian college-educated mothers with moderately high levels of food allergy management knowledge. The participants had moderately high levels of parental health literacy, empowerment, and advocacy. Most of them described an above average or excellent relationship with their schools. They described their youngest child in elementary school who had food allergies as having about 3 food allergies, with the most commonly reported food allergies being tree nut, peanut, and other allergens not listed in the top 10 food allergens. About half of the children had asthma, which is the major risk for fatality associated with food-induced anaphylaxis. Most of the schools were suburban and had a school nurse, and 90% of them required an individual emergency action plan. In terms of results, I conducted a regression analysis to predict parental advocacy with health literacy and empowerment. This accounted for 28% of the variance in parental advocacy. Then I used the process macro for SPSS to conduct a mediation analysis, and the hypothesis was accepted. So the indirect effect of on the pathway from health literacy to advocacy that was mediated by empowerment was moderate in size, positive, and significant. Furthermore, when we look at the change accounted for by the mediator, we see that was a difference of about 55%. That is the difference between the 0.25 and 0.11 was a decrease by about 55% that it was accounted for through the mediator of empowerment. Next, I tested to see whether reverse causality was a concern in the model. And I did this in 2 ways. First, the common statistical method is to reverse the mediator and the outcome variable. So reversing advocacy and empowerment. And when I did so, I have found a non-significant pathway. So with this test, I found that reverse causation was not likely an issue. Then next, I reversed health literacy and empowerment and ran the mediation analysis and compared the indirect effect size to the original mediation and found that they were somewhat similar in size. So I could not rule out reverse causality with this mediation. So what does this all mean? So the relationship between parental health literacy and advocacy may be mediated by parental empowerment. This adds to the mixed evidence about empowerment as a mediator on the pathway from health literacy to health outcomes. Yet I do recommend caution with this interpretation because this was a cross-sectional study that could not test temporality or cause and effect relationships directly. And furthermore, I couldn't fully rule out reverse causality in terms of reversing health literacy and empowerment. Strengths of the study included rigorous pre-testing and pilot testing of the measures and the methods. And one of the major limitations is that the study sample is not generalizable to a diverse sample of or population of parents with low educational attainment. It is quite possible that this sample is subject to selection and historical bias because data was collected during the COVID-19 pandemic. And that was a really stressful time for parents of children. In terms of implications for the field of health literacy, I did adapt a 3-dimensional health literacy measure using rigorous methods for children, for use with parents of children with a chronic disease or condition. And furthermore, the empowerment as a mediator may complement conceptual models of health literacy that contain psychosocial factors on the pathway from health literacy to health outcomes. This adds to that research. On a practical sense, the implications for public health are that when a practitioner is teaching a family about how to manage food allergies, they need to impart not just knowledge and skills, but find ways to enhance empowerment. One of the practical ways to do this would be through role play that increases self-efficacy and therefore increases parental empowerment. Future research should include assessment of covariates, such as the quality of the relationship with the school on the mediation analysis, and doing longitudinal studies to determine causality in the pathways. In conclusion, this study talks about the importance of parental empowerment and health literacy related to parental advocacy for safe food allergies management in elementary schools. I'd like to acknowledge that this could not have been possible without the help of all of the participants in the study and permission to use the scale the scales from Dr. Ishikawa and the Food Allergy Research and Education Organization. So thank you for your time.
So much, Laura. Are there any questions from the audience? While we're waiting for people to put in their questions, I wonder if you can comment. You mentioned that one of the limitations was about the sampling, and that lower income or more diverse populations were not included. I wonder what your hypotheses are about the relationships if you did have more of a diverse sample. Do you feel like empowerment would still have the same kind of relationship or not?
I think that it probably would have shown greater variation in the variables. So it would have had a wider range and a lower range, especially of empowerment. Empowerment was the variable that was kind of the highest level. And it probably would have demonstrated more clearly a relationship.
Great. And if you can comment a little bit more about ways to increase empowerment. You mentioned role playing as a potential way to address empowerment. Are there other strategies that you think could be helpful?
So I think empowerment, that role playing basically is the idea that it increases self-efficacy. As one does one, then they feel more comfortable with it, and then they can do it again in a live setting. That certainly would be helpful. The mediation does say that with increased health efficacy, then as empowerment as health literacy increases, then empowerment increases, and then that could help as well in terms of health outcomes. So I do think that there is a role for aiming at health literacy as well as aiming at empowerment.
Great, thank you so much, Laura, for that great presentation. I think we're at the end of our hour. And really great presentations from our 4 presenters. Thank you for that. And I will end the session here. I think there's a next session starting up at 12:30, an oral abstract plenary with Cindy Brock moderating. So I recommend you all attend that. Thanks, everybody.
Yes, if everyone could join us over there. Thank you very much. Thank you all the speakers. And unfortunately, we have to jump to the next room. Bye-bye.
Thanks.
Bye, everyone.
Bye.